Good morning. I, Chair Shelley Bailey, call the Prescription Drug Affordability Board meeting of May 21st, 2025 to order at 9:05 a.m. Pacific. Melissa, if you could please call roll.
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns.
Present.
Dan Hartung.
Present.
Lori Hoagland.
Present.
Robert Judge is absent. Chris Lehman.
Present.
John Murray.
Present.
Dan Kennedy.
Present.
We have a quorum.
Thank you, Melissa. I would now like to welcome everyone to today's meeting. We have an American Sign Language and Spanish language interpreters with us here today. I would like to introduce Jorge Guzman from Vive Northwest to explain the instructions for connecting to the Spanish channel. Jorge, welcome, and you have the floor. Jorge, thank you for providing that information to our Spanish-speaking audience here today. Our agenda begins with a conflict of interest declaration, which are stated according to board policies at the beginning of each meeting. Do any board members here in attendance have any declarations of potential or actual conflict of interest? Have board members met with entities or individuals related to board activities? And if board members have provided testimony related to prescription drugs to the Oregon legislature, please give the date and name of committee. But I do see that Mr. Murray has his hand raised. So Mr. Murray, you have the floor and welcome.
Thank you, Chair Bailey. My usual statement, please. Under advisement from the Oregon Government Ethics Commission, I declare a potential conflict of interest due to my ownership of Murray Drugs Incorporated. At most, according to the OJEC, I would have a potential conflict of interest here. Second comment too, I need to make an announcement that I did meet my request with Chair Bailey and Executive Director Magrish, about a request that we entertain the idea of expanding our discussions throughout the end of the year, having to do with experience that other states are using in order to save money for their taxpayers, insurers, and the drug delivery system. It's very much like what the letter from Oregon State Pharmacists Association, OSPA, submitted. I did not know that letter was coming to the PDAB board, but I wholeheartedly endorse the idea put forth there. This is the second month in a row, if not third, that we've heard people suggest that this PDAB go a slightly different direction than other PDABs in the nation towards steps that use or at least explore ideas that have saved money, not theories, not conjecture, but actual evidence of ways that the prescription delivery system has saved money in those areas. And so my request was that we look toward that. We see a lot of comments in the letters worried that, and we don't even have authority for upper payment limits, but they're concerned that that's the direction we're going. And so I would like to propose a slightly different tact for this PDAB board. Let's set a new course for this nation, even if the PDABs. Let's look at ways that already are saving money. That was my ask. So anyway, we'll, I'm sure, address that as we go through, hopefully. Thank you very much.
Mr. Murray, thank you for that information. And I do want to confirm that Ralph and I did both participate in that meeting. So thank you. Does anyone else have any declarations that they want to share before I advance to the approval of minutes? Okay. I would like to ask if members have any suggested changes to the draft minutes from the April 16th, 2025 meeting. And if we don't have any suggested changes, I would like to ask for a motion and a second to approve the minutes.
This is Board Member Murray. I would move to approve the minutes as presented, please.
Thank you.
This is
Mr.
Board
Murray.
Member Kennedy. I will second.
So I hear we have a motion and a second. Melissa, if you could please call roll.
Dan Hartung.
Aye.
Lori Hoagland.
Aye.
Dan Kennedy.
Aye.
Chris Lehman.
I'll abstain. I was not present at the meeting.
John Murray.
Aye.
Vice Chair Amy Burns,
Aye.
Chair Shelley Bailey.
Aye.
Motion passes.
Thank you, Melissa. I would now like to call on Executive Director Ralph Makridge to provide us with a program update. Ralph, welcome, and you have the floor.
Thank you, Chair Bailey. Good morning, everyone. A few brief announcements and updates. To start, pleased to share that our PDAB bill, Senate Bill 289, passed in both committees and signed by the President of the Senate on Tuesday and Speaker of the House just yesterday, and will head to the Governor's office for signature. As a reminder, that bill does three things. It proposes a language change from 9 drugs a year for affordability reviews to up to 9 drugs. Also removes the requirement that DCBS provide the board with the list of prescription drugs each calendar quarter, subject to 60-day pricing increases. And finally, that replaces the generic drug report annual requirement with a new provision that relevant content would be incorporated into the affordability review reports. That bill does not become conditioned on being signed into law by the governor. Of course, that bill would not go into effect until January 1st, 2026. Next, I want to thank all that took the time to participate in our affordability review surveys. Specifically, I want to thank patients and caregivers for sharing their stories with us. We had a tremendous response rate of 270 plus survey responses from patients and caregivers, and 28 responses from people with scientific or medical training, and that will be coming up later in our agenda as discussion. To that point, we also really want to take a moment and thank all of those who helped promote the survey, including pharmacies and clinics that posted the notice that we shared with them and the QR code for folks to respond, and certainly as well to all of those advocacy organizations that help promote it as well. Next, folks may note that we did pull an agenda item from our draft, and that was the discussion around the RFI for commercially available data sources and analytics. As we reviewed and started to develop that RFI further, we realized and recognized that new details in the scope of that project warrant a board discussion in the future. So staff is going to work with the chair to determine the best time to do that, and given our short-term priorities and calendaring of affordability reviews. So we will figure out what makes the most sense there. Next up, as folks may know, we are recruiting for a vacancy created by the resignation of board member Robert Judge, whose last meeting will be next month. We are recruiting specifically for a clinician with a knowledge and experience in the life cycle of patient care. I'll note that for newer board members, for perspective, this board was originally seated by the governor's office with 2 doctors, and we are looking to bring back that perspective. Applications are due on June 6th for an appointment to occur in September with confirmation hearings, and that new person likely joining us in September or October. Also invite any docs interested in this vacancy to contact me directly with any questions they may have. Also very pleased to share with you that our 3 members whose terms expire in December, being Dan Hartung, Dan Kennedy, and Chris Lehman, have all agreed to seek reappointment. So delighted that those folks want to remain with us and continue the good work that the board does. Finally, although you will be hearing a legislative update from Jesse O'Brien momentarily, I want to share with you some details about a couple of informational hearings that will be coming up in the House Committee on Behavioral Health and Healthcare tomorrow afternoon at 3 p.m. Trevor Douglas, the Director of Pharmacy Policy and Programs at OHA, will be presenting on statewide pharmaceutical purchasing. And then next Tuesday, the 27th, following the Memorial Day weekend, that same committee will be having an informational hearing about health insurance coverage of GLP-1s. And I am flagging this for board members' awareness, given the board has identified several GLP-1s on the subset list and our previous recommendations to the legislature around bulk purchasing. So to that point, staff will begin working with board members over the summer to start gathering potential policy recommendations and concepts for development into September and October. And to that point, and consistent with what board member John Murray just shared, this will also afford the opportunity for us as a board to pursue issues identified by individual board members who wish to advance the policy issues or possible savings opportunities for consumers and healthcare system as we contemplate those going into the fall. And with that, end of report, and I will invite Jesse O'Brien, the DCBS policy manager, to provide his update.
All right. Good morning, everyone, and thanks, Ralph, and members of the board. I'm Jesse O'Brien. I'm the policy manager with the Division of Financial Regulation at DCBS. And I did send a brief legislative update summary document out to the group via Melissa. Thanks, everyone, for that. And it is shorter than in previous months because as the session goes on and deadlines come by, bills are falling by the wayside. We are about to come up on one of the last major deadlines before the end of session, which is this Friday, which is the deadline for a bill to have a work session in a policy committee in its second chamber. So at this point, we're only talking about bills that have passed one of the chambers, generally speaking, unless they're in one of the exempt committees like Ways and Means. So all the bills in the list that I sent out are bills that are still currently active in the legislative process. Ralph noted that Senate Bill 289, which is probably the bill that most directly affects the board, has passed all the way through the process and is awaiting the governor's signature. Beyond that, I think probably the two most important or most substantive bills in this area that are still out there are both in the House Rules Committee, which is one of the committees that is exempt from the deadlines. Those bills are House Bill 2149, which would create a new licensure and regulatory program for PSAOs or Pharmacy Services Administrative Organizations, and House Bill 3212, which would significantly expand regulation of pharmacy benefit managers, PBMs. Both of those bills have been sitting in the House Rules Committee for quite some time at this point, but since the committee is not subject to the deadlines, there's still definitely the possibility that they could move forward. So we are keeping an eye out, waiting to see if we're going to be asked to weigh in on those in some way. The department, of course, would not take a position on those concepts, but we may get asked to provide informational testimony, that type of thing. There are a few other bills that are in process. There's one that is awaiting a Senate floor vote, which is the last hurdle before final passage, which is House Bill 2385, which relates to the 340B program and prohibits drug manufacturers from interfering with the 340B acquisition process in various specified ways. That one appears headed for passage, assuming that there's a successful Senate floor vote. And then there's a couple of bills that are in a bit of an unusual situation that also relate to the 340B program. One is House Bill 2057, and the other is Senate Bill 533, where both of them have actually passed out of the applicable policy committees, but have not been scheduled for a floor vote, despite having been sitting with the presiding officers of those chambers for several weeks, which is quite unusual. If I had to guess, what is happening is that these bills, like House Bill 2385, relate to the 340B program, and so there was perhaps an interest in trying to make sure that anything that touched on the 340B program kind of all went forward in an aligned package. And so there's been negotiation about what to do there. But it will be interesting to see if there's action on those bills going forward. But I think that's everything I have as of now. I'm sure we'll know more at the next board meeting. Any questions for me? If not, I will turn it back over. Thanks.
Okay, thank you very much, Jesse. I do want to follow up and mention that I would encourage everyone to review the board's website related to our recruitment for the open seat. We do have policies and procedures related to that. So anyone who is interested in participating, these are roles that sometimes we don't have vast numbers of people applying, but I would just please direct everyone to our policies related to participating on the PDAB board. So moving forward, we have two public comments periods today. The first public comment period today is for general comments. The second is for comments about specific drugs being reviewed by the board. For general public comment period, the board received 7 comments, which we have reviewed and have posted to the board website. I will read the list before I end this section. The board also received 5 requests to speak. I'm going to review those who provided written comment before I review those who asked to speak. So those who provided written comment were Olivia Backhouse from Aimed Alliance, Daria McGrew from Pharma, Brian Mayo from the Oregon State Pharmacy Association, Beth Ann Darby from the Oregon Coalition for Affordable Prescriptions, Tiffany Westrick Robertson from Each Pick Coalition, Derek Flowers from the Value of Care Coalition, and Olivia Canine from the Global Coalition on Aging. We also received 5 requests to speak. I will call on those who signed up to speak and ask them to state their name and organization. They have 3 minutes to speak. The board will not deliberate on issues or requests during this time. So the first individual who we have signed up to speak is Tiffany Westrich Robertson from AI Arthritis Each and Pick Coalition. Ms. Westrick Robertson, if you are here, welcome, and you have the floor.
Yes, hello, thank you so much. Tiffany Westrick Robertson, AI Arthritis, also ensuring access through Collaborative Health and the Patient Inclusion Council Coalition. I just want to thank you for this opportunity. And as always, I'm going to go a little bit rogue just based on conversation that I've already heard. I wanted to thank you for the opportunity and just start by saying I appreciate the statements regarding the consideration to position the Oregon PDAB to be innovative in thinking and focusing on cost-saving strategies that may have worked elsewhere, and would encourage any movement forward with these processes to include the review on how the cost savings benefited patients specifically and also the state. So making sure that we've delineated that benefit and clearly report who would benefit and how from these innovative approaches. Also an encouragement to lean on the Each Pick Coalition, particularly as we have the innovative Patient Inclusion Council and patients and caregivers to help with any of these approaches that you deem appropriate. Regarding the patient collection data, we do thank you again for including patient advocacy organizations. It was a little difficult to participate since the patient-facing survey was designed for individual responses, and we do appreciate keeping this open so that we can continue to collaborate and provide information on the 27 drugs. I am also happy to hear that over 200 patient caregiver respondents did participate. However, if we divide that by 27, that could be less than 10 people per drug. So I am a little concerned about the robust data and nature of the collection. So anything that we can do to improve that would be very welcome. We also encourage the board to keep the patient experience and real world affordability at the center of this work. A narrow focus on payer costs can miss the true impact on patient ability to access and adhere their medications. Any unintended consequences like new restrictions or access barriers must be avoided. We stand ready to work alongside the board and to offer the experience of our coalition, which includes patients across all disease areas. Thank you for your commitment for considering this feedback.
Thank you. We now have Brian Mayo from the Oregon State Pharmacy Association. Brian, if you are here, welcome, and you have the floor. What? Melissa, can you confirm if Mr. Mayo is here?
Yes, he is here. His camera's on. Brian, we are unable to hear you. It looks like that Brian's making adjustments to
Okay, we're going to move on
his
to
audio.
we'll move on to the next speaker, but we will circle back with him at the end of this section. So the next individual was Bill Schmickneck who is a patient protector. If this individual is here today, welcome, and you have the floor.
And Bill is here. Bill, I changed your setting, so you should be able to use there you go.
Can you hear me okay?
Yes.
We can. Welcome, and you have 3 minutes.
All right. Good afternoon. My name is Bill Schmitnick. I'm a father. I'm here as a father who lost his son to a system that prioritizes profit over patients. I'm also the co-founder of PatientProtector.us. It is an advocacy website specific to patient reform or a pharmacy benefit manager reform as a main goal, in addition to just overall healthcare reform. On January 21st, 2024, my 22-year-old son, Cole, who had a chronic asthma and was prescribed asthma or Advair as a daily maintenance inhaler, walked into a pharmacy, and after paying $66.23, his price jumped in 2024 without any notice or warning. The PBM managing his coverage removed the Advair from his formulary, and it wasn't because it wasn't effective. It was due to a non-medical switch, likely driven by rebate deals with the manufacturers. Specifically, when Cole went to refill his prescription, the price had jumped to $539.18, basically overnight. No one told him, no doctor said anything to him about it. No alternative was offered at the chain pharmacy he was at, and I specifically say chain pharmacy and not independent pharmacy. And Cole was fully insured at the time. That's the crazy thing. You know, this after Cole's death, we learned this wasn't an isolated event. It's happening across America. The pharmacy benefit managers, or PBMs, control formularies, drug pricing, pharmacy access. They take secret rebates, and they're not secret, from the drug manufacturers, driving up list prices. That's how they influence drug pricing. And who pays the price is the patient and these plan sponsors. Another big thing is they're squeezing independent pharmacies out of business. And that is going to cause more incidents like my son Cole, because he went to a chain pharmacy and he's no longer here because they did not take those extra steps. I know for a fact, because of an incident that happened with me, and I have the same asthma, at an independent pharmacy, I couldn't leave till they found something for me. Independent pharmacies are the cornerstone of our healthcare system. They know your name, they fight for your access, but they're being shut out by corporate middlemen who put money before medicine. We need to reform these big pharmacy benefit managers. We need transparency in pricing. We need protection against non-medical switching, and we need a healthcare system where no one dies because they can't afford the medication their doctor prescribed to them. On my mission over the last year or so, I've learned everything. I quit my job. I'm a full-time advocate. I travel to Washington. I travel from state to state because no one else needs to die. And that's a commitment my wife and I both have committed to. We're going to get justice for my son and make sure no one else gets hurt or dies. And we need to fix the pharmacy benefit managers. And thank you so much for my time today.
Mr. Schmitnick, personally, I'm very sorry for your loss. I'm very grateful that you're here today. So thank you for sharing.
Yeah.
I would now like to call on Derek Flowers from the Value of Care Coalition.
And I'm here.
Welcome, Derek. You have 3 minutes and you have the floor.
Well, good morning, and thank you for the opportunity to comment. I'm Derek Flowers, and I represent the Value of Care Coalition. We're a network of patient, healthcare provider, and caregiver organizations. Rather than detail each drug selected for review, our comments are focused on the upcoming process. We're concerned that the number of therapies to be reviewed, combined with the proposed timeline, will not permit for robust consideration required to ensure an outcome that takes into consideration all impacted parties. To date, none of your peer organizations have been able to complete cost reviews without facing significant challenges that result from such a complex undertaking. With 27 drugs plus insulin products chosen for review and only 5 months allocated to complete reviews, concerns arise about thorough and accurate data compilation, analysis, review, and deliberation. A process that prioritizes haste over rigor may lead to an erosion of public confidence in the process and in its outcomes. While the task before the board is complex, so are the conditions treated by the medications that you've selected for review. Whether it's a condition that used to come with a deadly diagnosis or one that was widely misunderstood and untreated until recently, the drugs used to treat them have been life-changing, if not life-saving. Each comes with their own value, known best by the patients who rely on them and the doctors who prescribe them. Cost and value are not the same, but these perspectives of value should be central to any discussion about the cost and affordability of a drug. The stated review plan is for each of the next 5 PDAB meetings to be spent discussing affordability reviews. Staff noted that up to 8 drugs could be reviewed at each meeting. In that case, with 3-hour meetings, it's possible that less than 20 minutes would be devoted to the entire presentation and discussion of each innovative, life-changing or life-saving drug. Hardly enough time to fully understand the value and deliberate its affordability. I hope you'll agree a discussion that brief would surely not measure up to the gravity of the topic being discussed. Unfortunately, these abbreviated discussions may lead to affordability determinations that also serve as the basis for future policy action. While the PDAB doesn't currently have authority to set upper payment limits, it's possible that authority will be granted in coming years. And as you know, there are great concerns about the unintended consequences of upper payment limits. Primarily, they don't guarantee patient savings and they threaten to reduce patient access. A recent survey of health plans validated these concerns, as did a recent survey of community pharmacists. These are the very people that determine patient cost and patient access, and they're telling us that they will pass costs on to patients, increase utilization management, and even stop carrying certain medications. These studies are cited in our written comment. So understanding that no state's been able to conduct these processes to an acceptable standard, that 27 drugs is far more than any PDAB has attempted to analyze, that 20 minutes of discussion per drug is wholly inadequate, that the drugs selected are life-changing, often with multiple indications that treat very complex conditions, that these hasty deliberations may serve as the foundation for public policy that carries great risk for patient access to treatments that are relied on, and that to date, this board has typically taken a very thoughtful approach to its decision-making processes. The Value of Care Coalition urges the board to consider significantly reducing the number of reviews it undertakes and expanding its timeline for completion. Thank you for your work on such a challenging and important issue, and again for the opportunity to comment today.
Thank you, Mr. Flowers. We now have Daria McGrew from Pharma listed to provide oral testimony. Daria, if you're here, welcome. You have the floor and you have 3 minutes.
Good morning, Chair Bailey, members of the board. Daria McGrew on behalf of Pharma, offering general comments today, not speaking to any specific drug, but more to the procedures and methodology of the board writ large. I want to go back to last year when the board decided to pause the reviews mid-process last year. You had a lengthy discussion indicating a desire to step back and look at first principles. One of those was deciding what it meant by affordability. And that has not been done yet. There hasn't been a significant discussion of that. So moving into the timeline set forth this year for review, if those reviews start in July, I would encourage the board to make sure that you have taken the time to have that conversation before beginning the reviews this year. We still have concerns about the process for deciding which drugs, as we've said, many throughout the process, there needs to be consistent and clear methodology. At the March meeting, you started with a systemic approach of organizing and filtering drugs based on clear standards in the database and filtering the database based on those clearly consistent standards. Unfortunately, we were disappointed when the board later began to debate drugs on a case-by-case basis. We think that the lack of consistent application of those standards leads to inconsistent rulemaking, inconsistent consideration of drugs, and can lead to arbitrary decisions. As a previous speaker mentioned, I do have some concerns with the number of drugs proposed at each meeting. I know that you have to find a way to fulfill the current statutory requirement of 9+1 and debate enough drugs in order to come to what you're required to by that current requirement, but I also think that it might stretch feasibility to perform meaningful analysis and discussion of each drug in the timeline laid out. And I do appreciate the board members and staff indication of offering as much time later in the meeting today for public comments on each drug, but also that there will be affordability public comment for each drug later in the process, just noting that today stakeholders don't have the reports to respond to and are simply responding to drugs appearance on a list, and will need to be able to respond at length later after the reports are published, and respond to information in those reports. So thank you for your time today.
Thank you, Ms. McGrew. I do want to circle back with Brian Mayo from the Oregon State Pharmacy Association. Melissa, if we can confirm he's here and if his audio is working, we would like to welcome Brian.
Are you able to hear me now?
We sure can.
Yes.
Welcome, Mr. Mayo. You have the floor and you have 3 minutes.
Great, thank you very much. My name is Brian Mayo. I'm the Executive Director of the Oregon State Pharmacy Association. I have submitted written comments that are on pages 99 and 100 in your packet. OSPA commends the PDAB's ongoing work to improve transparency and affordability in prescription drug costs. However, I want to urge the board to take more actionable steps by learning from other states that have successfully implemented cost-saving strategies. Specifically, OSPA calls on the elimination of spread pricing by PBMs, a practice that inflates drug costs and burdens patients through higher copays, premiums, and limited access to affordable medication. My written public comments highlight successful state models in Ohio, New York, Kentucky, and West Virginia that have saved millions by banning spread pricing, using transparent reimbursement methods, and restructuring PBM contracts. OSPA urges PDAB to adopt similar evidence-based reforms to provide immediate broad-based savings and improve access to medications for Oregonians. You have a statutory requirement to determine 10 drugs for the upper payment limit, but banning spread pricing will lower prices on all drugs and have an immediate impact for all patients and taxpayers. If he were attending this meeting, Robert Judge would oppose this idea, as he has done in the PBM workgroup meetings for House Bill 3212, hosted by Representative Rob Noss. Banning spread pricing has been opposed by the insurance carriers and PBMs during our meetings because it obviously changes the status quo, which is exactly what is needed to help the patients. Again, I want to encourage you to eliminate PBM spread pricing in Oregon and pursue transparent, cost-based reimbursement systems proven effective in other states. Thank you.
Thank you, Mr. Mayo. We are now moving to the portion of our agenda where we discuss the timeline, process, and voting methodology for affordability review determinations. One of the purposes of the PDAB is to conduct affordability reviews on prescription drugs and insulin products as directed by ORS 646A.694. Today, Courtney Whitlock, Senior Policy Analyst, will continue our discussion from the April 16th meeting about the timeline, process, and voting methodology for the board affordability reviews. Courtney, welcome, and you have the floor.
I'm going to take a moment and share my screen. And as Chair Bailey had mentioned, we had started this discussion last month, and I'd like to dive into it a little more thoroughly for this meeting. Again, the same calendar timeline as last month, indicating that we did get through the surveys that were submitted, and it's still under analysis, as well as the data call information from the carriers. We were in the process of doing those write-ups in collaboration across a couple of the teams. Our main focus is to kind of discuss how the setup starting in June should apply to the drugs and the additional information provided through the data call. I don't have a sampling of the data call information, but again, next month we're really going to dive into it, and this is why I need the board's guidance in how to start looking at removing any of the drugs on the current subset list to narrow it down a little bit. We do know that there are at least 4 drugs that have the designation of an orphan designation, and they will be removed. At this time, over the last few months, we have not had a conversation to remove them prior to the June discussion. I wanted to make sure that everything was done in one conversation. So before I move into the listing for more details, was there any questions or comments from board members regarding the initial timeline, kind of how things are set up? And Chair Bailey, I see your hand
Thank
up.
you, Courtney. Just for the record and for everyone that's listening in today and for my colleagues, could you tell us what those 4 drugs are that had orphan status that we'll be removing, just so we consider that when we go through today?
Well, so we're not reviewing any drugs today. So
Well, I meant when we were listening, but okay, so we will talk about that in the next meeting.
yes, thanks. I don't want to derail that.
That makes sense. That makes sense. Thank you.
And let me just make sure. Okay. So, and I do really appreciate board feedback at this time. So starting off with the conversation, we do have the list of subset drugs. We've been sitting on these drugs for a while, and I would like to ask the board members if there's anything besides leaning into the information from the data call to consider, to look at as we start setting up the next review. And if not, then I will ask the board a couple other questions, but I want to give the board opportunity to provide me any insight on how else to look at the subset drugs. Yeah, John, I see your hand up.
Just one topic or thought for me is, how long have these drugs been on the market? If they're still one of the most expensive drugs of the list, and they've been on the market past patent expiration date or for some time after, I'm curious. I would like to look at those drugs and know why they're still one of the most expensive. Just a thought.
Thank you. Yeah, we can put that together and as well as information around any therapeutic alternatives or bios associated with that drug. That was kind of one of the ideas. Dr. Hartung?
Yeah, I kind of echoing some of the public comment we got. I do have concerns about the number of drugs we have to review over the next month's cycles. And I don't know what the magic number should be, but I think we're going to be, racing through these things. And I just have a lot of concerns about that over the summer months. And so I don't know if we can kind of think about maybe a top end upper limit of drugs to review to meet our legislative requirement, but still have a meaningful discussion during the review process. So removing obviously the orphan drugs, and then maybe thinking about some other way to kind of just limit the number of drugs that we're going through.
Yeah, and that's again why I'm trying to set up this conversation right now. So as we start looking at the comparison of the data call information that's come in to the current subset list, we can start setting up where it'll be easier for the board to kind of have top identifiers to make those decisions, and we'll know right away kind of when those fall off. I think a big thing is to understand how the board would like the drugs to be categorized, but I'll jump into that as soon as Chair Bailey has her opportunity to respond.
Oh, it was just more some other ways to try to look at it. Again, I do, for the record, recognize we are not having the discussion about what is or is not on the list today. But one of the kind of things that we may want to talk about as a board is not related to drug specific, but do we want to have any discussion about like how many drugs, absent of the insulin products, do we want to have any discussion about how many drugs we might want or should there be in a therapeutic class? I mean, those are the types of things, if we have a discussion right now, Courtney, that could help us for next month? Is that in alignment with some of the guidance you're looking from us on today? Or do you still want those for next month? I guess those discussions for next month.
Yeah, it might be a little bit better suited because you'll have we'll show you the number of the therapeutic alternatives,
No, I'll table that for next month then. I was just trying to give you any additional guidance that could be helpful for this.
Yeah, I appreciate that. And again, this is staff is just needing some board insight and like how we want to set up some of the data to make it easier for the conversation for next month. And I know it's kind of hard because you don't have the subset list in front of you. I can pull it up, but I don't want us to start having a conversation about how to drill things out. It's just a collaborative discussion about how we integrate the data call information to the subset list. And if there's any key points that you understand from your industry that would help staff kind of set things up in a meaningful way.
I mean, Dr. Hartung had his hand first.
So we're getting the data call, getting the data from the data call for the next meeting, and you're asking about how you can organize that data for us. Is that what the ask is here? I'm a little confused on what insight we need to provide now.
Well, when we look at the drugs, is there any way that we can set it up? We plan to hopefully have the database or the dashboard to provide information. And I know that staff deals with the data a lot more than the board, so it's probably challenging to say, well, we can conceptualize it in this way. But any feedback from your point of view as the professionals that are in your line of work, that you see drugs and their alternatives, or that would help staff to kind of make it meaningful to see? Is it cost more important? Is it the number of therapeutic equivalents and alternatives? Is that more important? Is it the difference in price concessions based off of the difference between what we may pull from APAC to the data call information? So just trying to think pretty broadly about what are ways to look at data for these drugs that are under review. And Laura, I see your hand up.
So I agree, it would be good to limit it. It would also be good to think about organizing it so that we want to get a lot of input from patients and caregivers, providers. So if we did review them with regard to disease condition, it might be a little bit easier to have that feedback be comprehensive at the time we're looking at the medicines.
Yeah, and I plan to, so we had all the survey information come in. I will be incorporating some of that feedback from the patient survey, like how the impact was from a data perspective into that. So I appreciate that feedback because that is something we're planning to do as well. Thank you, Lori. So as you kind of think about ideas, and you don't have to, if you can't come with guidance right now, that's, you have a couple weeks to respond to me, or just like send me an email if something comes up for you. One of the things that I'd really appreciate board guidance on is how the order of the drug review should go, as far as like, is it more meaningful to look at drugs that are most costly, the biggest impact, or most costly based by utilization? Want it done alphabetically? Like, what is the order that we start looking at the setup in the bucket? So like last time we categorized it by the therapeutic class, and the review was done through the therapeutic class. And I just want to make sure that I'm capturing the board's preferences in setting up each of the upcoming reviews. Dr. Hartung?
I think it makes sense to group them by therapeutic area. It's just so we're not jumping from disease state to disease state, if where possible.
Appreciate that. Any other feedback or agreements with Dr. Hartung utilizing it by?
I agree with Dr. Hartung. Oh, Dr. Burns.
Yeah, I mean, I agree. I think it's going to be challenging in some of these drugs where they have multiple indications and are for multiple disease states, which is what we ran into last time too. So it's kind of challenging for the some of the medications that are used for a lot of different immune conditions to just say they're dermatology, which is where I think we landed last time on some of these, which I don't know. Maybe I'm just being nitpicky because that kind of bugs me. But
No, this is why we're here to have the conversation.
I mean, it's as good a good a way of doing it as any. So I guess I'm just grumbling.
And I'm happy to, Dr. Burns, if there's another concept, by all means. But John, I see your hand up.
Yeah, I'm of the opinion that 27 or 24, 23 are too many, and that it does need to be pared down for us to make a meaningful discussion. Therapeutic categories are fine by me. It was mentioned in some of the letters that whether it's cardiovascular or HIV drugs or cancer drugs, that they're suggested selecting some from each and not having all of them, or having a disproportionate number in one particular therapeutic category. That might be something to consider as well.
Okay, I'll look at that. And Dr. Hartung, I saw your hand was up. Did you have anything before going over to Dr. Burns?
Well, it's just I have these reoccurring concerns that similar to what John Murray just brought up about just the number of reviews that we're setting up and just having not enough time. And I'm just thinking through this whole process about like what the ramifications are if we get to the end of the, whatever the list of drugs we go through, and maybe we have to come up with a list of 9 at the end of the day. Is that what our mandate is?
Identify 9 that create challenges.
It's so hard to like a priori decide how many review to identify 9 that maybe have affordability challenges. And so I guess like, what if we go through all 20 and we're like, well, none of them don't, we don't think that they present affordability challenges in the state for X, Y, or Z reason. Like, what happens? It's hard for me to wrap my mind around this process with that as a potential outcome.
Yeah, and I definitely hear the concerns. Staff is also concerned with the number of material packets we have to, develop to get the information and stuff like that. But again, these conversations about the structuring of the review process is what staff needs from the board members, and again, leaning into your expertise on ways to apply the data for the review of the cost, because that's basically what it is. But I'm going to give Dr. Burns an opportunity since you've had your hand up there. Dr.
I'm still thinking. I'm gonna take my hand down, but thank you. Sorry.
Shelley, it's okay. Shelley.
Ralph had his hand raised. Ralph, do you want to go before I?
Yeah, thank you, Shelley. Dan, I think just in response to your broad comments and what's been noted in public comment, we need to go through the exercise, as in fact one of our public commenters noted, that this remains a statutory obligation and responsibility of the board. To that point, it is imperative, I believe, and important the board make a good faith effort to complete the exercise. To the point noted that if we find ourselves in October, whatever that shakes out to be on the calendar, and to the hypothetical that you noted, what if the board has a list of 20 drugs and deems none of them to be those that may cause affordability challenges? The board will have completed its exercise and its obligation and commitment to the legislature, and in fact, demonstrating its depth of bench, knowledge, and understanding, its expertise, its engagement with citizens and consumers throughout the entirety of this process, and will have made that bona fide good faith effort consistent with our statutory obligation. And if the board at the end of that exercise is to say to the legislature, we did not find any of these to be unaffordable, we found 3 of them, yet we looked at 20. Again, I would say hang your hat with pride in having met the obligation and done it through a rich, engaged, robust process. So hopefully that provides some level setting of expectations and that factors that are often beyond our control in terms of data compilation, timeliness of receipt, all these different things will roll into the commitment for this board to make a good faith effort to complete the exercise. So Chair Bailey, I'll invite you to pick up, or Dan in response, whomever would like to.
Oh, I guess, thank you, Ralph. Glad you went first, but mainly just wanted to share something that I heard Courtney say, and I think Dr. Hartung, I heard it too, is essentially kind of the word cost. And that is a lot of what, we're looking at right now is when we're looking at these reviews, cost is kind of the data that we have right now. So it's just something I heard while we were talking that I thought I would mention. But Dr. Hartung, you have the floor.
Yeah, thank you, Ralph, for providing some clarification or thoughts about the process, because I just really I'm quite uncomfortable with this process and what we're setting us up for, because we paused the process last cycle, and I would much rather have a very limited set of drugs, maybe even 9 to review, and just be very, very deliberate, given that this is our first time through fully, and we're going to be familiarize ourselves with the data, how the data are arranged, kind of what to consider, what we think about affordability. Like, it's just such a huge task at hand. And so I would much rather have a very deliberative process with a select set of drugs, and maybe come to maybe 1 to 2 maybe drugs that are we find to have affordability challenges. And I'm just remembering that Colorado, I think that they just identified 1 drug that was 1 or 2 drugs that had affordability challenges. So I know they're operating with a different legislative mandate, but it just seems such a high bar to meet this 9 drugs out of, identified 9. It's just arbitrary kind of out of our subset list right now. Anyways, those are my thoughts.
And they're good thoughts. And Dan, again, that's why our statutory requirement is changed, and starting in 2026, we can review up to 9. For now, we're still at the 9, and hopefully how we're setting things up, we'll be able to identify, some that have impact. But I think next month when you see the data, at least you'll be able to know which ones wouldn't qualify to continue for the review process, just because of the additional information submitted under the data call. And then hopefully that will narrow the list down quite a bit. But I wanted to give Lori a chance to comment.
I just wanted to reiterate that idea of selecting fewer in one therapeutic category as a way of reducing the work we have to do so we can be deliberative. I think that's something that doesn't go against our mission here.
Thanks, Lori. I appreciate the feedback. There's a couple other points I did want to discuss with the board members. I know on this slide it has, when to bring in public comments. I don't want to put too much time on that because we know that's the same process as last time. And I will ask the board maybe as we starting in our next month to maybe clarify what that guidance would be. But moving on to the next slide. Maybe. When process
Courtney, if you can pause, I think Chair Bailey wanted to recognize Lori for a moment, or may have something.
I think Lori her hand was still up from the last time.
Sorry.
And Chair Bailey, your hand.
Yeah, the only thing I wanted to say related to public comment was just to mention that we do have 85 minutes today denoted to that. So, we do have people that provided letters and have signed up to speak. And then at least from my own personal thought process as we move through the affordability reviews, because I do think, we do have to talk about this as a board, is I guess I had always intended that when we got our packets that it would seem reasonable that anyone that wanted to provide public comment related to the drugs that were currently in the packets, that we would be using our public comment period of those meetings for people that signed up for those specific drugs. That may be way too basic of a perspective, but that was one of the perspectives I had, which is also why we were having today's meeting, because we wanted to open it up for overall kind of feedback and then narrow it as people signed up for different drugs that may be in a packet. But that's just one way to look at it.
Yeah, I appreciate that, Charlie. And again, just as another portion of conversation, just to help for guidance, moving into insulin. So in the last review, insulin was reviewed first, and then the additional drugs were reviewed after. Is it more meaningful for the board to review the insulin product kind of first? Do you want to review it last, or spread it out across each kind of review month? Or is it more meaningful to actually see the data next month and then provide staff with guidance on how to set that up? The reason I kind of want to get ahead of that question is if you wanted to review it in July, then I know what drugs to focus on for the material packets. If it's going to be weighted on them, I'll focus on the other drugs instead. John?
Thank you. On the insulin products, this one is a particular interest to me because they're all, I believe insulin glargine is one we selected, and there's what, 9 to 10 products that are all insulin glargine. I would like to see all the products, initially the information to them, because I'm looking for idiosyncrasies in pricing. It seemed like the chart that we had before had some outliers as far as cost and impact to the patient, to the insurers. I'm personally wanting to see this product or this study be on insulin glargine. And then if we need to break off, if there's 8 that are similar and there's 2 that are standing out as far as affordability, I want to study why. So that's my take on it. And I would do it all at once, and then we could refine it from there.
I guess, is there a preference, board, if you review it in July versus October, another month? And Dan, I see your hand up. You don't have to answer my question but I want to get to you that too. You can go ahead, Dan. Oh, you're on mute.
I agree with Mr. Murray. I also think that they should be a insulin glargine review session packet, and we probably need to devote more time than another standard drug, just because it's going to have a diversity of products in the glargine set. So we just need to budget out more time for that particular review. I don't know if it matters when in the process we do it, but we just need to have more time for that one.
Chris, your hand up.
Yeah, I agree with both Dan and John on that. And I think it makes no difference to me, Courtney, if you would want to do it in July, because then you'd know what you were working on for these next few weeks or whatever. It's fine with me if it happens in July, but agree it should be one meeting.
Okay. Appreciate the feedback. I'll work with that. And just in the interest of time, I do want to just ask this last question, which is the voting process. How the vote, does the board is more interested in applying votes in each month to move drugs forward that would ultimately be identified in November as a drug to review? Or is it the intention to just to have all drugs reviewed again in November and then a vote structure done there? And shall I see your hand up?
Thank you. Just in reflecting on previous years working on this, I think my personal opinion would be to listen and learn and then not conduct the vote. And we recognize we're not pitting one drug against another, but I think strategically it makes sense that we listen and hear all the feedback, and then we vote at the end of hearing all the feedback. But open to discussing other ways, but from my perspective, that would be essentially the way I would be inclined to go.
Thanks, Chair Bailey.
Do you have feedback or best practices about this?
Up to the board. Chris, I see your hand up.
Yeah, I mean, I agree with Chair Bailey. That makes the most sense to me. I mean, because what we think in July after hearing one presentation, our opinions and the way we're looking at things could potentially change over the course of those months and the reviews that we do with other ones. So I wouldn't want to box ourselves in by having approved 8 or something like that very early on and still having reviews that are going on. So it makes the most sense to me to do the vote at the end.
All right, well, those are the main points that I needed to ask the board for today. Going on with the rest of the timeline outline. Again, today's meeting, we're gonna hear from constituents, consumers, and people in the industry, kind of regarding their experiences with drugs that are on the subset list to hopefully provide some more guidance in how to review the drugs for next month. June being, pretty data heavy analysis. Oh, Chris, before I move on, I want to acknowledge.
I just wanted to make sure that the rest of the board agrees with Chair Bailey and what I commented. I know that they didn't say anything, but that seems like a pretty big decision that we're going to change the way we did the voting compared to previous years to wait until the end. Was the silence agreement, I guess would be my question.
I see John's hand up.
Yeah, I agree with both of you. Thank you.
And Dr. Burns?
I don't have a preference. I think that your rationale makes sense, so I'm fine with that.
Ms. Hoagland?
This is my first time, so I feel that what has been put forward would be fine. I would support it. Makes sense.
All right, well, we will set stuff up to do in that way. And Dan, I see your hand up?
Yeah, I just thought I'd chime in and say, this is my first experience as well, so I'm good with waiting till the end.
Okay.
So
Thank
yes, silence was affirmation in this case.
Gotcha. So thank you again. I will start working on ensuring that the process is set up in a way that is meeting your requests and your feedback from today's conversation. Going into next month, again, we're going to be looking at a lot of data. So I will be doing touch bases with everybody and to ensure that there's an understanding of the data with the new information from the data call and survey responses to provide some meaningful conversation to the upcoming, and then hopefully provide the guidance to how to best look at the drugs to either keep them on or remove them. Yes, John, I see your hand up.
Yeah, please. So prior to, just as soon as I can get the information from the subset list again, could it be sent out to me or to us so that if we get a chance to work on it through the month, we can manipulate that data again, please? I need to revisit that set, please.
Yeah, a lot of it comes down to what's going on with the data call submissions. There's been it hasn't been as easy as we were hoping to get the carriers to submit the information for us to clean and structuralize easily. So we're still working on creating a meaningful and cleanup for the analysis. But once we have the information that we can get to show you, then absolutely we'll send it out as soon as possible. And Dr. Hartung, I see your hand up.
Yeah, I don't know if this is something to be decided now or in June, but I was just looking at this final one of these slides here on the review timeline. It says if no drugs are removed from the current list, the addition of the selected insulin products may lead to a review of approximately 8 drugs each month. which is, I feel like is way too much. And so I wonder if we want to either now or next month figure out what given, you know, we have a limited number of time, what the maximum number of drugs we want to review per month is, as a kind of target of like where we need to winnow this thing down to.
And again, that's the hope that going back and revisiting the subset list with additional information from the data call and the RFI and the conversations from patients and industry today will help that conversation be fueled next month.
So next month we can do that.
Yeah.
Okay.
You know, and really looking at what that number should be. But Chair Bailey, see your hand up.
No, I was just hoping to remind everyone we do have 85 minutes denoted for public comment. So I just wanted to mention that we're currently over time already. So I was just wanting to make sure that we had this discussion and then we had time for the generic drug report.
Yeah,
Just
I'm almost done, and then we'll transition over to the generic drug report. So, and then John, I see your hand up real quick.
Yeah, just a brief comment in regards to Dr. Hartung's comments. I honestly am shooting for 10 drugs and an insulin, 9 drugs and an insulin in the back of my mind. Just throwing it out there.
All right. Well, next month will be hopefully a really good conversation once you get to see the data as well. And then kind of back to the timeline, July through October will be the review of the drugs and the categorizations that the board provided guidance on. November will be the discussion and voting for the drugs and the insulin products, with the final report being in December. So thank you for your conversation and feedback on that. And Chair Bailey, I'll send it over to you and I'll start getting the generic drug stuff.
Perfect. Thank you, Courtney. ORS 646A-697 requires PDAB to prepare an annual report about generic drugs. Last month's board members reviewed the draft report and members submitted changes which have been incorporated into a final report. Today, the board will review the final report and vote on it. Courtney will lead us in the discussion. So Courtney, thank you for helping us with reviewing and voting on the generic drug report.
Chair Bailey, so this is the draft design that was set up and sent out. There's a component towards the end of the report that was added this morning into it that was accidentally omitted during the cross between updates and the design. But it was added back in this morning, so I'll point those out here in a few minutes. Thank you for all the board members who contributed feedback and information. Nothing had changed from last month's draft report, and anything that was added for additional information was highlighted in red. I did ask every board member to please review any content in red so you can provide me the approval of it so we can get the vote done. So we're going to start here with this one. Basically, this is additional information about the graph here, figure 1. Is there any concerns, or just kind of with a thumbs up if you're all in agreement that this section is okay, then I'll move on to the next one. All right, I see thumbs up, so I'm going on. Thank you. We will approve that. Dr. Hartung provided some write-up regarding the ADHD medication supply. I again requested everybody to take a review of that. Any feedback or comments? If not, then thumbs up will give me the indication we want, but I see John's.
I was just going to comment, this was very much our lived experience through this time with the shortages and why it happened. So it was good to see the explanation so that people can understand. Thank you.
Yeah.
I would just make one suggestion maybe just spell out the acronym attention deficit hyperactivity disorder first time it's used.
Well, we may have done it at the top, but
Okay.
I can go back in just to make sure that it was. But yeah.
Sorry, just nitpicky.
No, it's okay. Yeah, I'll take that down and make sure that I thought I had put it maybe at the top in another section. But for this section in itself, I do understand why having it called out here would be easier. Okay. Let's see. So this is additional information was provided, just the highlight of the executive order from the current administration. Was this a additional information? Any concerns? If not, thumbs up will let me know to move on. All right, got majority. Again, additional information provided regarding costs for the Medicaid in Oregon, kind of highlighting claims and costs. Dr. Hartung, I see your hand up.
I just had a question or a confusing comment about the table, and it says, so it says generic drug use percentage, and the first row says generic drugs. And then it has, you know, mental health carve out, fee for service, physical health, and counter physical health drugs, which a little bit jargony terminology there, but that's fine. I just, the first line doesn't make sense in terms of like, if the row is generic drugs and generic drug use percentage is 91%, that doesn't kind of make sense. But so if I'm interpreting it right, it means that across mental health carve out, physical health drugs, and counter physical health, the blended or the aggregate average was 91% use. And then within those different groupings, that's how it breaks out essentially.
That's how I read it.
Yeah, that's how I understand it too.
Okay. Maybe just change the generic drugs in that first row, just to say like total then, or something like that.
Okay, we can do that. Does the rest of the board kind of agree with that suggestion?
Yes, please, because I did not understand this clearly the first time I read it.
Alrighty, do that. Thank you, Dan. Appreciate that feedback. And then this was just another clarifying statement in here. Does the board agree to incorporate this small paragraph? If so, just give me a thumbs up. I see majority. And then the last component was under the GPO section that was highlighted. There's additional information and some restructuring of the content. Does this look good to everybody? Any comments, feedbacks, or suggestions? All right, seeing none, I will take it as an approval. And then I apologize, this section was not in the original posting online. It was added this morning. It was just an oversight. So this has been added in, and this is none of this language changed from the original review from last month. So apologize that that wasn't initially incorporated into the final. Chair Bailey, I see your hand up.
Thank you. So this was in the April packet.
Yes, this is the April packet, and this is the information that was omitted from there, but it is now in the document to be posted. So with the agreements of the couple changes to highlight the ADHD, and then to change the table on the Medicaid component. Melissa, can you get ready to post the votes if the board is in agreement to
Yes.
vote on it? And thank you again, board members, for reviewing and helping staff set a lot of this content up. All right, we just need a motion from a board member. Thank you.
This is Board Member Murray. I would motion to approve the final generic drug report to send to the Oregon Legislature with the changes mentioned today in our discussion.
A second.
For the motion for the second, Melissa, could you please call roll?
Dan Hartung,
Aye.
Lori Hoagland,
Aye.
Dan Kennedy,
Aye.
Chris Lehman,
Aye.
John Murray,
Aye.
Vice Chair Amy Burns,
Aye.
Chair Shelley Bailey.
Aye.
Motion passes.
Thank you, Melissa. I would like now to announce that the board will take a 5-minute break and we will return at 10:25 a.m. Pacific. Welcome back. Melissa, if you could please just call roll so I know we have quorum before we proceed with the next portion of our agenda.
Yes. Chair Shelley Bailey,
Present.
Vice Chair Amy Burns,
Present.
Dan Hartung,
Present.
Lori Hoagland,
Present.
Dan Kennedy,
Present.
Chris Lehman,
Present.
John Murray.
Present.
We have a quorum.
Thank you, Melissa. This is the public comment period for the affordability review per ORS 646A.694. The board has designated this time to hear from people about each prescription drug being reviewed by the board. Each speaker will have 3 to 5 minutes, although the chair has a discretion to grant more time. Board members may have follow-up questions of these speakers. We will hear from the people and groups in the following order outlined in OAR 925-200-0020. Patients and caregivers, individuals with scientific or medical background, pharmaceutical manufacturers, advocacy groups, safety net providers, and pharmacy benefit managers. Additionally, the board received 25 new letters. The letters are posted on the PDAB website and reviewed by the board. I am now going to read the name and organization of individuals who sent us letters, but again, I encourage everyone to review those on the board website. In order, that's Andrea Todd Harlan from Sanofi, Gabby Gardner from Basic Rights Oregon, Anne Murray for Bristol Myers Squibb, Kathleen Costello, Multiple Sclerosis Coalition, Jane Leo, American Cancer Society, Christy Banks, Gilead, Michael Valenta, Johnson & Johnson, Tim Layton, Genentech, Seth Grenier, National Multiple Sclerosis Society, Christian Omar Cruz from GSK, Stacy Pham from Boehringer Ingelheim, Cynthia Ransom, Eli Lilly, Courtney Pirone, Novartis, Albert Faro, Cystic Fibrosis Foundation, Dr. David Bernard Page, Providence Cancer Institute, Isabel Sheridan, a patient, Suzanne Mistaris, Community Liver Alliance, Linda Nelson, OCAP, Mary Watcher from Genentech, Rainier Simmons, CAN, Scott Bertrani from Health HIV, Joanne Strobel from APFE, Molly Guthrie from Susan G. Komen, Sarah Hoffman, Partnership to Advance Cardiovascular Health. The board also received 10 requests to speak. I will call on those who signed up to speak. Please state your name and organization and the prescription drug you will be speaking about. Again, each speaker will have 3 to 5 minutes, but please keep in mind board members may ask questions of the speakers, so we want to make sure we allow time for board members to ask questions. So the individual that we first have on the list is Carol Elkins, a patient who is retired, and this oral presentation would be related to Mounjaro and Ozempic. Is Carol Elkins present?
Carol is not present. Maybe we could come back to her.
We'll circle back at the end. So the next person that we have signed up on our list is Lindsay Silva, a mother and primary caregiver to someone living with cystic fibrosis related to Creon. Is Lindsay Silva here today?
I am, yes.
Hello, welcome. You have the floor.
Hi, thank you so much for having me here today. Again, my name is Lindsay Silva. I have a 21-year-old daughter, Ella, who has cystic fibrosis. Ella was diagnosed at 6 months old due to failure to thrive. She had practically fallen off their growth charts and was hovering right around the 5th percentile for both weight and length. We had come to find out it was due to one of the hallmarks of cystic fibrosis. Due to a thick, sticky mucus that was blocking her pancreas, digestive enzymes weren't making its way into our digestive system to properly break down food and absorb vitamins and nutrients. Ella was immediately started on a pancreatic enzyme replacement therapy, specifically the medication Creon. She started to gain weight immediately and would eventually get back onto a normal growth curve. Throughout the past 2 decades, there were times when our health insurance had changed, and Creon was often not the new insurance provider's preferred enzyme. So there are different formulary exclusions. We had problematic prior authorization protocols and hoops we had to jump through. There are a handful of digestive enzymes on the market that all have mostly the same active ingredients, but different enzyme strengths or variations in the not active ingredients can make one enzyme product tolerable, while another can be almost like not taking enzymes at all. Over the years, Ella was made to fail on other brands before being allowed access to Creon once again. And if you're wondering what it's like to fail in a digestive enzyme, it's exactly as bad as you think it is. At best, it's hours and hours in the bathroom, and at worst, it's intestinal blockages, surgeries, and hospital stays. It's been well documented that nutritional status is tied to pulmonary health, growth, and long-term survival. For Ella, from that first week of diagnosis, actually almost exactly 21 years ago this month, I knew that maintaining a healthy weight was going to give her the best chance at a future. Just like there's over 2,000 different mutations of the cystic fibrosis gene, every person's cystic fibrosis is vastly different, and what works for one patient does not work the same for another. It's imperative that Creon be readily available as part of the arsenal of medications necessary to allow people with cystic fibrosis to maintain some measure of overall health. In addition, because enzyme dosages change with growth, it's essential to have full access to all of the multiple strengths of Creon. When Ella was 6 months old, we started with the tiniest pill when she was such a tiny girl. So she was taking just 3 Creon 3000s with every meal. Today at 21, Ella takes 5 Creon 24,000s with every meal and snack. If that 24,000 strength wasn't available, she would be swallowing 40 pills before every meal. The day-to-day burden of living with this chronic disease is a heavy lift. Having access to proven necessary medications is crucial. In Oregon, 2/3 of patients who require pancreatic enzyme replacement therapy are prescribed Creon. Whether through private insurance or state-provided coverage, Creon is an absolutely crucial medication. Today, Ella just finished her junior year in college, something that I wasn't sure was going to even be possible when we first got that diagnosis 21 years ago. It's only through access to necessary medications that have worked for Ella to treat and control her daily chronic symptoms of this chronic disease. If she had not had Creon, I cannot confidently tell you that she would be here today. I completely understand that you guys are at the beginning stages of this process, and I appreciate the opportunity to clearly illustrate early on the importance of Creon to Oregonians living with cystic fibrosis. And thank you so much for your time and consideration for allowing the patient and family voice to be at the center of this discussion, because at the end of the day, we are the ones who are going to be living with your decision. Thank you.
Thank you for being here today. Before I move to the next individual, Ms. Hoagland, your hand is raised. You have the floor.
Just a couple questions for Lindsay. One is that in your experience, were there times when you had one dose that was not appropriate for your daughter on the formulary, but not the appropriate doses? It sounds like you may have had to give her multiple pills at some times. And the other question is, in your experience, what amount of time did you have to try an alternative before it was deemed a failure and you were given prior authorization?
So there were times that I'm sorry, the first question was about
the dosages.
Yes. Thank you. So because of different enzymes have slightly different amounts in each of them, depending on the manufacturer, there are times when we were made to move from Creon to a different one that did not line up dosage wise. So it was either meant that she was going to be having to take under the amount that was necessary or over the amount that she was supposed to be taking. And her care team did the best that they possibly could to make that as equal as possible. One of the things about cystic fibrosis, obviously, is you get get older and your weight gets more and you're eating more, you need more of an enzyme. And so we work really closely with dietitians and our team's pharmacists to make sure that that dosage is never over what it should be for your weight and age group, but also that you have enough. And every person, it's a little bit different. And so it's kind of trial and error. So when you find a dosage and that works, you like staying with it is super important. As far as failing on a medication, it usually had to be a pretty specifically documented week of time where we had to show, that. But even one day of failing on a digestive enzyme is like Ella couldn't function in life basically for those days that she wasn't able to be on the medication that she should be on.
Mr. Murray?
Yeah, Lindsay, as a pharmacist, a community pharmacist, I've seen this happen 100 times, and I feel for you because unless you have an advocate that's really ready to fight for you, whether it's your care provider or your pharmacist, you really suffer through these things. And a lot of people give up, honestly, because they just can't endure the process. So thank you for your testimony on this process. It's one of the failures, in my opinion, of our healthcare delivery system, in my opinion. I think they're cumbersome burden barriers.
Thank you so much. I often worry about the community that doesn't have the job flexibility or the time to spend making phone call after phone call and chasing down prior authorizations and getting the right medication at the right time.
Dr. Hartel?
Yeah, just a quick question. Thank you for your conversation. Just it sounds like most of your issues with access were related to insurance company restrictions, formulary issues, rather than out-of-pocket costs of the medication. Is that true? Would that be a true statement or generally true?
Right now there as far as I know of, well, specifically for Creon, there are manufacturer copay assistant programs that help our community out a lot. One of the things that the Cystic Fibrosis Foundation has done is made sure to shore up those programs available to our population. But I do know that half of all children in Oregon and 1/3 of all adults who have cystic fibrosis are on Medicaid, are on some form of Medicaid and need assistance. And when they're on those programs, then right now those copay assistance programs are not available. So copay assistance is just for private insurance support.
Great. Thank you.
Yeah.
Sorry, Dr. Burns, I see that you have a question. After your question, we will advance to the next speaker, but welcome.
Thank you for your testimony. So would you advocate that we add Creon to our list of medications that we look for affordability issues on?
I actually don't. I feel like the affordability of Creon is not one that's a heavy burden on our population. Right now, our concern is maintaining access for people and making sure that there is access across the board, regardless of what kind of coverage you have.
Thank you.
Thank you. I do want to circle back to the patient Carol Elkins to see if they are here today. If they are not, we will retry again towards the end of the public comment period. Melissa, can you confirm if Carol Elkins is present?
Carol is not yet present.
We will check back later. So the next individual on our list is Gabby Gardner from Basic Rights Oregon related to HIV medications. If Gabby is here, welcome, and you have the floor.
Gabby is also not in the meeting, Chair Bailey.
Thank you for making me aware. Next individual on the list is Zach Linkiewicz from HIV Hepatitis C Policy Institute. If Zach is here, looks like you are, welcome, and you have the floor.
Good morning, Chair and members of the board. My name is Zach Linkiewicz, and I'm the Government Affairs Manager at the HIV and Hepatitis Policy Institute. Thank you for the opportunity to speak today. We do not believe HIV medications, including Odefsey, should be part of this affordability review process, given their unique clinical role and the systems already in place to ensure broad access. Access to HIV treatment in Oregon is already supported by a well-functioning safety net, including Medicaid, the Ryan White program, the 340B program, and manufacturer assistance. These programs work together to keep HIV medications affordable and widely available. In 2023, 83% of Odefsey users in Oregon paid less than $5 per month, and nearly all insured individuals had coverage. Care Assist, Oregon's ADAP program, also plays a key role in helping low-income residents get their medications with little or no out-of-pocket cost. Affordability in HIV care isn't just about the price of the drug. It depends on a broader system that reinvests savings from the current drug pricing structures into patient services. Programs like Care Assist and 340B don't just help cover medications, they also fund case management, adherence support, lab monitoring, and clinical care. If affordability reviews eventually lead to reimbursement caps, that could reduce the funding these programs rely on and jeopardize both access to treatment and the essential services that keep people healthy. In recent months, the federal government has taken steps to suspend or restructure key HIV programs, contracts, and personnel. These interruptions threaten more than 3 decades of progress in treatment access and prevention. They've created uncertainty in the funding streams and service networks that people with HIV rely on every day. At a time when our national infrastructure is already under strain, additional state-level interventions, such as an affordability reviews or upper payment limits, could compound that disruption. Even without UPL authority, affordability reviews can influence insurer decisions that restrict access, including tighter prior authorizations or step therapy. For people living with HIV, these are not minor issues. Disruptions can lead to viral rebound, drug resistance, or the need for more complex and expensive regimens. Each new HIV infection can cost the healthcare system nearly $850,000 over a lifetime. It's also important to remember that HIV medications are not interchangeable. The right regimen depends on resistance history, other health conditions, and the patient's ability to stay on treatment. People who are stable and virally suppressed should not face new coverage barriers. Everyone benefits from patients to payers when the people with HIV remain undetectable and engaged in care. We support efforts to reduce out-of-pocket costs, but the real affordability challenges lie in insurance design and PBM practices, not drug pricing. We respectfully ask the board to reconsider the inclusion of HIV treatments and focus instead on solutions that meaningfully improve patient access. Thank you for your time.
Do any board members have questions for the speaker? Oh, looks like we saw lots of hands raised. Ralph, I see yours as well.
Let's see. Shelley, let me defer to board members first and we'll circle back. Thank you.
I don't know who came first, but Vice Chair Dr. Burns, you have the floor.
Thank you. I appreciate your testimony, Zach, and I really do appreciate what you're saying about patient affordability. I'm curious though, what's the list price for Odefsey?
That's a good question. I don't have that readily available. I apologize.
So if there weren't programs available or insurance coverage wasn't comprehensive and people had to pay out of pocket at the list price, would that be a significant cost?
It sounds like the vast majority of patients only pay less than $5. So without those programs in place, and they had to play for the very few people that had to pay out of pocket and full list price. Yes, I imagine that would be a price that would be challenging for them to afford.
So I only bring this up, and I don't know that I necessarily personally agree that we should include HIV meds on this, but that we are also looking to the cost to the system, and that list price can really significantly impact the system. So that's just another thing that we have to look at as a board.
Mr. Kennedy, your hand is raised.
Yes, Zach, thanks a lot for your testimony. Appreciate it. So my question is kind of a broad question. So would you advocate for exemption of all HIV medications from this program?
We would, given the reasons that I stated. HIV is unique in terms of the treatments are not interchangeable. Disruptions can result in resistance, transmission, or treatment failure with this particular disease.
Thank you.
And I guess I'll go ahead. I had a question and a comment. I guess I too, like Vice Chair Dr. Burns shared, I'll reserve the discussion related to medication placement for next month's meeting, but I did want to mention two things. Could you tell us more, Zach, about the maximum $5 for HIV medications? Are those manufacturer cards, or what? Can we just confirm for all of us here where that comes from?
It came in the report that the report that Gilead submitted.
Through manufacturer assistance.
Yeah.
Okay, through co-care cards. I was just trying to make sure I knew where the source of that came from. And then just to follow up on Dr. Burns's comment about list price, if someone was uninsured or didn't have access, it does look like from copay card programs that someone might access that most know the names of, it would look like it's about $3,700 a month. So back to Dr. Burns's comment about list price, $3,700 a month is probably what someone who was uninsured would pay if they could not access other programs.
Thank you for finding that. I apologize in front of me.
Chair Bailey, thank you. You asked the question I was going to appreciate.
Okay, great. I saw your hand was down, so I figured you didn't have more to add there. I do want to ask, are there any additional questions before we invite our next speaker? All right, looks like there are not. Thank you again. Next individual that's on our list is Lucy Thornhaven from the National Psoriasis Foundation related to Humira. Lucy, if you are here, welcome, and you have the floor.
Hi, can you hear me okay?
We sure can. Welcome.
Thank you. Good morning. My name is Lucy Thornhaven. Thank you for the opportunity to speak today. I am a patient living with Crohn's disease, and I have been using Humira to successfully treat my Crohn's disease since 2016. And I also am the government relations manager for the National Psoriasis Foundation for the Western region. So I bring both my personal and professional experience to my public comment today. So we feel that obviously reducing the cost of care is important to all Oregonians. And it's also important that any policy recommendations made by the board to the Oregon legislature doesn't carry any unintended consequences that might negatively impact patient access in this complex, nuanced drug supply chain. Because of the heterogeneity of diseases like psoriasis and like Crohn's, as well as the drugs used to treat diseases such as this, it's important that patients like us have access to the full range of treatments available to us. And so we caution the PDAB to be on guard against creating any scenarios in which potential upper payment limits would incentivize insurers to re-tier formularies or restrict access to drugs, or even eliminate certain drugs from their formularies. Any incentive structure that makes it more difficult for patients to access the full range of treatment would create major barriers to care for people living with chronic conditions such as myself. Personally, since I was diagnosed with Crohn's disease back in 2012, I've tried and failed 8 different medications, including other biologics, until I was able to successfully go into remission using Humira. So it's crucial that I am able to maintain access to this drug, so that I can not only live pain-free, but also avoid high hospital costs that I was incurring before I was in remission. So we also want to commend Oregon for passing other bills aimed at reducing costs to patients, such as House Bill 4113, which was passed a little over a year ago, protecting copay assistance, making sure that that goes towards folks out-of-pocket costs and deductibles. At the National Psoriasis Foundation and myself as a patient, we really encourage the board to, look at the whole supply chain and the whole scope of what patient affordability means, including the importance of copay assistance and how that plays into the ability for folks to pay for their drugs. For instance, if you say that Humira is roughly $8,000 a month for a twice monthly dose, which is what I'm taking, it's important it's imperative to note that the role that copay assistance plays, because even if you were to reduce an $8,000 drug by 75%, that's still $2,000 a month, and that wouldn't be affordable to myself, and I doubt that that would be affordable to many people. So this just raises the question, if the board does get access to setting upper payment limits, it just raises the question of what upper payment limit could be set that actually would bring down the cost for patients on an individual level. All of that being said, at the National Psoriasis Foundation, we did commission a study from a research firm called IQVIA, and we would be happy to share some of those results with the PDAB. The commission was to study and assess the out-of-pocket costs of patients in other states that have similar PDABs and setups. And so we would be happy to share those results. Yeah, thank you. Thank you so much for the opportunity to speak today.
Absolutely, thank you. Do any board members, oh, Dr. Hartung, I see you have your hand raised. You have the floor.
Yeah, thank you for sharing your perspective on psoriasis medications. I guess one comment and one question. Yeah, so if you could share with the board at some point the IQVIA study that of PDAB states, that would be helpful. Second point or question I wanted to ask was, from a patient perspective, I guess the typical psoriasis patient perspective about access to immunologic drugs, is it a challenge to kind of get settled on a preferred therapy in the way that the system is currently? Is this is it common for patients to have to cycle through commercial insurance or Medicare or Medicaid to navigate that? Is that currently a challenge that most patients or the typical patient faces?
I would say yes. And because of some state protections that we have in Oregon, like state level protections regarding step therapy, some people are protected from some of those extra barriers to access, but that doesn't apply to everybody. So people in Oregon that are on employer-sponsored health plans, ERISA health plans, often are subject to step therapy and made to go through several different trials of medications. And I do work with several patients that have experienced that, as well as, insurance formulary barriers like non-medical switching and things like that. And another unique aspect that comes with these autoimmune conditions like psoriasis or Crohn's is that if you are on a medication that is working for you and then you switch insurance or you switch jobs, and you're made to go to a different medication, once you're able to go back to that preferred medication at some point, it doesn't necessarily always work like it did before. So those disruptions in care, we've heard lots of stories of advocates at NPF that have experienced those complications.
Thank you. And Dr. Burns, we'll have you ask the next question and then we'll move to the next speaker. So Dr.
Yeah,
Burns?
mine's really quick. Thanks, Lucy. Just outside of upper payment limits, and I definitely heard what you were saying there. Do you advocate us looking at medications like Humira for, say, Crohn's on the affordability review?
So we at MPF we try to remain, as neutral as possible. We appreciate that the work that you're doing. But I think we caution against anything that could potentially disrupt access. And so we are wary of a medication like Humira being deemed unaffordable because we're not sure the ramifications of that, if that makes sense.
Thank you. Thank you, Lucy, for being here today. And the one thing I will add, since we were referencing upper payment limits, is I do want to make sure to reinforce that this board does not have any control or decision-making related to upper payment limits. That's not in the scope of what our board is working on at this time. So I do want to move to the next individual who has signed up, which is Mary Jo Strobel from APFED related to Dupixent. Mary, if you are here, welcome, and you have the floor.
Hi, yes, thank you so much. My name is Mary Jo Strobel. I'm Executive Director for the American Partnership for Eosinophilic Disorders, or APFED for short. APFED is a 501c3 patient advocacy organization founded 23 years ago to support patients and families with eosinophil-associated disease. We represent patients nationally with roughly close to 3,000 people subscribed to our emails, 88 of whom reside in the state of Oregon, in addition to thousands who engage with us through other platforms. Eosinophilic esophagitis, or EOE, is a chronic allergic inflammatory disease of the esophagus that occurs when the tissue becomes infiltrated with eosinophils, which is a type of white blood cell. The excessive numbers of eosinophils cause inflammation in the esophagus. This condition affects both children and adults. The symptoms can vary by age. Infants and young children can present with vomiting, reflux that doesn't respond to medication, as well as poor appetites and failure to thrive. In older children and adults, symptoms can include difficulty swallowing, chest pain, food impaction, which is when food gets stuck in the throat, in the esophagus, and persistent reflux that does not improve with acid suppressors. EOE can significantly affect a person's quality of life and their ability to eat and drink normally, leading to weight loss and malnutrition. Chronic inflammation and scarring may cause esophageal narrowing, increasing the risk of food getting stuck and requiring emergency medical intervention. EOE treatments include dietary restrictions, reflux medicine, swallowed corticosteroid, and dupilumab, which is available under the brand name of Dupixent, which received orphan drug designation from the FDA for the treatment of EOE in 2017. And it's now FDA approved, indicated for EOE for both adults and children in the US. This drug can be life-changing for people with EOE, and it's critical that those who rely on Oregon's public health care programs have access to this drug. Clinical studies have demonstrated that dupilumab can significantly reduce the inflammation in the esophagus, improve symptoms of EOE, and lead to visible improvements in the esophagus of both children and adults after treatment. So today I urge this council to consider the limited FDA treatment options that are available for eosinophilic esophagitis and to ensure that those in Oregon have equitable access to care. lack of treatment can lead to disease progression and more costly medical complications, ultimately increasing the state's healthcare burden. So I would respectfully ask that you take into account the orphan drug designation of Dupixent and Oregon's statute of excluding drugs with this status from affordability review. And I thank you for your time and your thoughtful consideration.
Thank you for being here today. Do any board members have any additional questions? All right, thank you, and we will
Thank you.
the next speaker. The next individual that we have signed up that who I'm aware is also present is Rainier Simmons from CAN related to ODEFC. If Rainier is here, oh, I see you. Welcome. You have the floor.
Hello, good afternoon. Can you hear me okay? Okay.
Yes, we can. Thank you.
Good afternoon. My name is Rainier Simons. I'm speaking today on behalf of CAN. We're a national nonprofit organization focused on policy issues related to HIV, AIDS, viral hepatitis, and all chronic disease conditions. And I'm also speaking today as an antiretroviral patient. And I'll be echoing some of the thoughts of the other gentleman who spoke about ODEFC, and additionally added some other information about that. So I'm speaking today to express that ODEFC should not be on the list for consideration for affordability review, given that it is an HIV antiretroviral medication. In previous board deliberations, there initially was a robust discussion about excluding HIV medications from review. There seemed to be agreement that protecting access to all HIV antiretroviral medications was important from a public health perspective, and because data shows that the majority of patients do not have any affordability issues with drugs like ODEFC, because there is ample assistance from patient assistance programs, as well as low affordable copays. However, in a subsequent meeting, one HIV antiretroviral was excluded only because there was an orphan status indication for pediatrics, and the other one, ODEFC, was added to the list for consideration because one of the dashboard filterings indicated a high total net carrier spend. The priority should be patient access and affordability. Net carrier spend does not describe the ability of patients to afford their medication. Since pricing control caps can possibly result in adversely affecting patient access, including possibly increasing costs for patients, ODEFC and HIV antiretrovirals should not be up for consideration. The nature of HIV requires unencumbered access to all available antiretrovirals. It is not just a nicety or a convenience, but a matter of treatment success or failure. I personally have had to change antiviral medications 6 times because of harmful side effects I developed, including in one case where the drug was damaging my kidneys, and another where my liver was being damaged. If at any point my access to one of the 6 medications was disrupted or blocked entirely, I would not have been able to switch and would have suffered serious medical consequences, including the possibility of losing my viral suppression. With all 6 medications, I never had any issue of any affordability. Across the time span of all 6 medications, I had several different insurance plans with varying patient cost shares. For every drug, the patient assistance programs enabled me to get my medications for no cost or very little cost. There was even one period where I did not have any insurance at all as a result of losing it due to a layoff. I was still able to get my medication for no cost through the ADAP program. So today I do urge you to please exclude HIV antiretrovirals from affordability review.
Thank you for being here today. Do any of my colleagues have any questions of this speaker? Okay, without questions, again, thank you for being here today. The next individual who is signed up to provide testimony is Olivia Canine from the Global Coalition on Aging related to ODEFC. Melissa, if you can please confirm if Olivia Canine is here.
Let me double check that. Actually, Olivia is no longer here.
Okay, I appreciate that feedback. So we will move to the next individual who has signed up to provide testimony, which is Silas Martin from Johnson & Johnson Medicines. If Silas Martin is here, welcome. I see that you are. You have the floor.
Hello, good morning. Thank you. I am Silas Martin. I'm the head of Access and Policy Research at Johnson & Johnson, and I appreciate the opportunity to discuss Tremfya and Xarelto today. We respectfully ask the board to exclude Tremfya and Xarelto from its affordability reviews. We find there's a lack of evidence that these medications pose affordability issues for the patients in Oregon or for the healthcare system. So for the board today, I have 2 general and 4 product-specific comments to share. So first off, general comment, payers ultimately decide what patients pay for their medications. And over the last decade, Johnson & Johnson has reduced net prices for various products by 20%. And in 2023, our rebates, discounts, and fees to pharmacy benefit managers, private plans, and others reached a high of $42.8 billion. These efforts are intended to make our drugs more affordable and accessible to patients, and yet pharmaceutical benefit managers and health plans do not often pass these cost savings on to patients. And to the extent that patients do not directly benefit from these efforts, the board should examine the role of PBMs and health plans in this process. Second comment, general comment, we urge the board to clarify this review process and methodology. As has been discussed earlier, we're unclear how all these reviews could be done on 27 drugs in a thorough and evidence-based way within the time frame. So I know you're considering that, but we also reiterate that. So turning now to Tremfya and Xarelto, to note that we offer various programs to support patient access for Tremfya and Xarelto, and that eligible patients pay as little as $0 per month for Tremfya and $10 for a 90-day supply of Xarelto through our savings programs, and that uninsured or underinsured patients may be eligible to receive these medications at no cost through our patient assistance program. Second, the PDAB does not indicate that Tremfya and Xarelto create affordability challenges for Oregon healthcare system. And I'd say that neither drug appears on the most recent carrier-reported top 25 list of Oregon drug price transparency reports used for the affordability reviewers. And so this questions why they should be on this list. Third, the PDAB dashboard should be updated to align with the latest data in March and April 2025 spreadsheets to reflect that actually FDA-approved generics for Xarelto in that timeframe. Finally, Xarelto should be excluded from review because it is subject to a maximum fair price under the Inflation Reduction Act, one of last year's exclusion criteria. This decision is critical as we've already begun to see the unintended consequences of some of the coming MFPs. For further detail about these points, I direct your attention to our data submission and supplemental materials, which attach this meeting. So we know that patients are counting on us to develop and bring to market accessible medications, and we live this mission each day and are humbled by patients who trust us to help them fight their diseases and live healthier lives. I appreciate your time today. Thank you.
Thank you for being here. Do any of my colleagues have, looks like Mr. Murray, you do have your hand raised. Mr. Murray, you have the floor.
Thank you, Chair Bailey. Silas, thank you for your comments. A couple of questions or thoughts. You mentioned that it isn't on the most recent list of information of top 25. I guess I'm asking staff also, this is newer data that's come out since the data that we're reviewing is here. Is that correct?
That's the information I'm referring to. Yes, I think what's over on the website.
Okay. And I also take note of the idea that the savings that Johnson & Johnson is trying to pass on to patients doesn't always get to them. And I guess I'm just a comment on the whole process that we're doing here with the PDAB. I'm hopeful that I'm not a fan of UPCs. I'll just come out and say that. I am a fan of this board, this group, studying why savings such as you mentioned don't get to the patient. Where are they getting stuck? Where are they getting gobbled up? Where are they getting doubled down on? Where are they, just not working? So I'm hopeful, I'm thankful for like Silas and, Rainier and Zach talking about the HIV drugs. And so I'm glad those are there. And I don't want to do anything with this board that would jeopardize the programs that are there, the Ryan White or the CARES or any 340B entity, for example, by setting an upper payment limit. However, as a community pharmacist, I see such a patchwork of assistance programs to patients that it can be so discouraging. I hope that this board will shed light on why the savings aren't getting to the patient, why some patients are completely left out and some are helped so much. I want them all to be helped. So Silas, I appreciate your comments. Thank you. I'm no specific questions, but I appreciate you bringing up some of those points. Thank you.
Thank you.
Ms. Hoagland, I see that your hand is raised. You have the floor.
I guess my question is somewhat similar in that I've had a couple of patients who were prescribed it in emergency room, hospital settings, and they were not able to get that assistance with a quick, urgent problem.
I'm sorry to hear about that. I don't know the specifics of those, but it is available, and I would encourage those systems to learn more about it. We're happy to reach out to those systems.
Vice Chair Dr. Burns, you have your hand raised. You have the floor.
Yeah. Hi, I was wondering if you could talk more about how Johnson & Johnson has lowered the price for one of these or each of these medications, like year over year. So for example, what was the average list cost for Xarelto in 24 versus 23?
What I spoke about earlier is the rebates and discounts that we offer through all of the insurance companies that we work with, and that those net prices have decreased year over year for by 20%. And so
outside of the net price, though.
Outside of the net price.
Mm-hmm.
Well, we offer a lot of information about how those discounts are made available through our transparency report website, and it is difficult to discuss, the price a patient pays, because it is determined by their insurance, and that is where we try to provide these services and programs to bridge the gap between what the insurance sets the price at for the patient and what they pay.
So it's really difficult for us, based on the data that we get, to be able to see that, because we don't get to see, say, rebated data. We don't get to see what you're describing as the net price, which is why I'm trying to get you to tell me, like, what the not net price is. Like, what was the difference in the list price between 23 and 24 for, say, Xarelto?
I think there are commercially available databases to do research on out-of-pocket costs, and we do that internally. And so that is what I think the board could focus on, is looking at the out-of-pocket costs for patients in Oregon to see the distribution of those costs for Oregon.
I understand, because we do get that. We do have the out-of-pocket, like the, not necessarily rebate, but the out-of-pocket costs. I was just trying to get out, like, what you're pricing the drug at on the market.
I don't have the specific information available at this time for you.
Okay, thanks.
Do any board members have any additional questions? Mr. Kennedy, your hand is raised.
Yeah, Silas, thanks so much for your testimony today. So I'm curious about something you said, the unintended consequences of the MFP negotiations. I'm wondering briefly, because I know it's very complex, if you could speak to a few of those unintended consequences.
Yes, so more detail is in a testimony, but one example is at the community pharmacy base level. Many community pharmacies would have to, through the implementation of the IRA, have to float the cost of pharmaceutical at waiting for time for adjudication. And so that's an example of pressure that it could put on the supply chain of the MFPs. And so they're preparing for that, but that is something that, an example of how price setting for specific settings can interfere with the supply chain.
All right, without seeing any, Mr. Murray, you have your hand raised. You have the floor.
I was just going to mention, as a community pharmacist, and a number of other community pharmacies in Oregon recently met, and this topic, MFP drug program, is a major concern to carry these medications only for Medicare patients, but we have to buy it at the higher price and wait for the manufacturer to pay us back, and we get to carry that, we get to float that. The PBM doesn't have to. They pay us what the rate is for the lower. And so it's this program is discouraging, actually, because then there's a mandate that if we don't supply this drug for this program or for Medicare, that we are in trouble. We are, as a pharmacy, excluded.
Do we have any additional questions of this speaker? Okay, without further questions of this speaker, thank you, Mr. Martin, for being here today.
Thank you.
Yeah, absolutely. The next individual that we had signed up to speak was Carol Elkins, related to Mounjaro and Ozempic. Melissa, if you could confirm whether or not this individual is in attendance today?
Carol is not in attendance today.
Okay, so this was my last call for that speaker, so we will move to the next individual. We also had Robert Nolan from the Arthritis Foundation related to Humira. Could you confirm if this individual is present?
Robert is not in the meeting.
Okay, that's my last call for that speaker. And then the other individual that I had signed up was Olivia Canine from the Global Coalition on Aging. Could we confirm if this individual is present today?
Olivia is not in the meeting currently.
Okay, that was my second time asking for that speaker as well, so I will no longer be asking for that speaker. So with that in mind, I would like to mention that our next board meeting is June 18th, 2025 at 9 a.m. There being no further business before the board, all in favor of adjourning the meeting today, please say yes.
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 Any opposed, please say no. Okay, well, our next meeting again is on June 18th, 2025 at 9 a.m. Pacific. Thank you, everyone.
Thank you.
Thank you.